All right, welcome to this pharmacology review on the drug class inhaled corticosteroids. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from what to the why. Patients with obstructive lung diseases like asthma, COPD, have benefited significantly from the development of a large number of drug therapy options, most of which are inhaled medications. The inhaled corticosteroids are one of the major contributors of these treatment options. They have historically been used as one of the primary maintenance or preventative treatments for the management of asthma. In my 30 years of experience working as a nurse, pharmacist, physician, and teaching in academia, I watched the inhaled corticosteroids literally evolve and find their place in the management of COPD, but only for certain patients. The question is, why do they work so well for asthma, but only for a select group of people with COPD? Well, this is where the learning to understand enables us to understand that why, where we can impact patient-oriented outcomes the most. And this drug class can certainly do that and has the evidence to support it. So let's jump into talking a little bit about the relevance in more detail about these inhaled corticosteroids. And let's answer this in the context of both asthma and then COPD. So let's talk about asthma first. Well, when we look at why we would study this drug class, it is and I mean the primary component of the chronic outpatient management and is known to reduce exacerbations, other medication use, improve quality of life, and reduce mortality. I mean, that's huge. I mean, this drug class needs to be used first before anything else. That's how important it is in asthma. Now, what about COPD? Well, it has a limited role, as you heard me talk about just a few minutes ago. It's typically limited, but has a great role in certain patients with moderate to severe COPD who typically also have exacerbations in their history, okay? And have elevated eosinophil counts, typically over 100, okay? And these drugs have also a lot of evidence to support their use to improve symptoms that reduce their need for hospitalization and going to the hospital for additional treatments and the risk of exacerbation. So that's relevant for both disease states within the obstructive diseases, lung diseases. All right, so what medications and indications make up this drug class? Well, the drugs that make up this class include beclomethasone, budesonide, ciclesonide, fluticasone, and mometasone, right? And the two indications that we talked about are mainly asthma, first line, primary first treatment, and then a select group of people with COPD, okay? So how then do these medications and indications connect with their mechanism of action? Let's take a look at that. Okay, when we learn mechanisms, it's important to put it in the context of also the anatomy, not to get into extreme amount of detail, but I think having that orientation helps us to also understand why certain drugs work when they get to the right location. And with inhaled corticosteroids, we need the drug to not deposit in the oropharynx, not go down the esophagus. We need it down into the very distal parts of the airways where this inflammation can cause more obstruction, mucus production, and that's where this remodeling and all this stuff starts to happen, whether it's asthma or COPD. So what I'd like to do is first start out big and then kind of start to zoom in, and then we're going to get into one of the areas where inhaled corticosteroids work on the inflammatory reactions that occur at the cellular level. So we partner with anatomy.app, which is an excellent service for understanding anatomy and the parts and really studying that. So if you need that, we provide a link for you in our description of our video and at thisiswhy.health. Please click on that, and if you feel like that's a great service, consider that. It's a great company and service. So Bro's hanging out with us. If you don't know Bro, he's one of my old residents. He doesn't have any parts left. We put him on, we're taking his parts and over here, so he wants to hang out. Make sure you guys know that he's thinking about you. Just kidding. All right, let's jump into what's going on here in the chest. So on the left side here, you can see we have obviously the rib cage, and you can see an example of obviously the right lung, and then over here, obviously the left lung has been removed. But I just wanted you to see the orientation of where the lungs sit and the heart as well. But I want to take notice of a couple things. So I'm just going to rotate around here, and I'm going to kind of look at the top. So right here is your trachea. This, obviously your airway comes in, you breathe in, and you pull the stuff down into the main bronchi that then go down through these branched parts of the airway. But you also see the esophagus is tucked in behind here. And this is relevant so that when you are inhaling medication, yes, we want it to go down this way, and that's why the technique is so important. We want to maximize the aerosolized drug to get down this tube, not go down this tube. Now, some of it is going to move down this way, and that's why you can swallow a certain amount of medications that you can absorb systemically. And when we inhale it, we're trying to mostly give topical coverage. We want to treat the local anti-inflammatory properties at that level, not all over the body. Remember, we talked about, we're going to hear a little bit in a minute about side effects and things like adrenal insufficiency, bone mineral density, immunosuppression. We don't want to do all that, okay? So it matters. Now let's look back here at the lungs. I want to point to something else, and I'll zoom in a little bit more here in a minute, but you can see some of these airways have cartilaginous rings. Those cartilaginous rings are keeping the airway open. Well, we'll see that change as we go a little deeper. Now let's dive a little deeper. Okay, so this is now a view. We've obviously removed the ribs, the heart. The heart obviously fits inside this cavity. You've got your trachea, and then we have the carina, and then the main bronchi that lead. So we've got to get that drug coming in from the mouth down through here and keep traveling, because we need to get to these distal airways in the lungs. Now you can see here in this anatomy that the right lung here has 3 different lobes, and the left lung has 2. Okay, so that's important to just recognize from a normal anatomic position. If you were to rotate in and you look inside here in the cavities, these are where a lot of the other blood vessels for the arteries and the veins that are perfusing it to take venous blood to get oxygenated and to return it back to the heart to get it oxygenated, and then the arterial blood coming back that is going, venous blood, really it's arterial, until it gets into the heart and kicks out in the aorta. Right? It needs to bring aorta back here. That's what this stuff is in this area. All right, now let's look at the bronchi in particular, because again, we're going right here. Let's go a little bit deeper. Okay, so what you see here is as the bronchi continue to branch, you still see these cartilaginous rings. All these rings are holding the airways open. Now, that doesn't mean that the patient can't still experience plugging, right? Mucus plugging from the inflammation, the edema, the swelling we're going to talk about here in a second, fill up these tubes. Those things can cause obstructions. That's why asthma is an obstructive lung disease in part. Whereas in COPD, the lungs collapse on themselves because they've lost the elasticity and compliance and the tone of some of these distal airways. But Remember, we've got to get the drug to come down through here and up through and go down into these small areas to get to the bronchioles, which we're going to look at next. So here's again a zoom in on the structure of the alveoli, and you see all these sort of pockets, but what you also see is that there's no cartilaginous rings holding this airway open. This is where our bronchodilators technically need to get. If they don't make it to this area, they're not going to cause bronchodilation. That's why the technique is so important. I will talk about the techniques of different devices, whether it's a metered-dose inhaler, a dry powder inhaler, or nebulizer. The right technique facilitates the deposition of the drug in the area where it's going to work. So that's why it matters to understand this. This is where airflow volumes, especially things like FEV1s that we measure on a pulmonary function test, are really regulating the volume of flow through this area right here. Okay? So it matters. Now we need to zoom in at the cells, because that is where the steroids are primarily going to work when we get it there. Okay, so we're now zoomed in on the cell, and there's this, what are steroids doing? So they finally travel through all those tubes and they land. They got to exert their pharmacologic effect, the pharmacodynamic effect. What is it going to do? Okay, first and foremost, with asthma and COPD, allergens and environmental pollutants and things that we are breathing in are triggering our immune system. And that triggering of the immune system is what creates the symptoms that people have. The shortness of breath, the cough, that eventually leads to wheezing, right? Decreased ability to exercise, their tolerance is decreased. Why? Because there's something blocking the airflow throughout that whole entire airway down to the alveoli. So what is facilitating that? A lot of it is edema and swelling and secretions. Well, why are they forming? It goes down to this. So let's take a look at it. So in our cell membranes, we release something called arachidonic acid, right? Now, arachidonic acid is an omega-6 fatty acid. Now, the thing that triggers that arachidonic acid to be released from the cell membrane is an enzyme known as phospholipase A2. So this enzyme is controlled by genes, just like other things. So a gene can turn on and make more of this enzyme or make less of it. And that is one of the places that steroids target. They decrease the production of this enzyme that decreases the release of arachidonic acid. Well, why would we want to do that? Well, if you release arachidonic acid, it has one of two pathways to go down. It can go down the lipoxygenase pathway and form leukotrienes. And leukotrienes are known to do a number of things. They turn on and they recruit more inflammatory cells from the white blood cells. They recruit and release and cause constriction and also change the permeability of the tissue at that level. What does permeability changes do? Well, it causes fluid to leak out. That leads to edema, swelling, secretions, mucus plugging, obstruction. Well, what also happens when we turn on and stimulate the immune system with all these leukotrienes? Well, they release chemicals, neutrophils start to come in, and they release chemicals, and that can cause remodeling. That's what happens in COPD. Well, what are the predominant white blood cells that show up in asthma? Eosinophils. Now, that doesn't mean that COPD patients don't have eosinophils. They do. It's just more allergic asthma-related symptoms. Hyperactive airway disease is more eosinophil-based from allergen exposure. And COPD is a kind of remodeling obstructive lung disease that is predominantly influenced by neutrophils. And neutrophils in COPD release a lot of proteolytic enzymes that destroy tissue, and in destroying the tissue it causes remodeling. That's why we want to stop and regulate these things. We got to stop the recruitment, and they're turning them on. So leukotrienes are one of the mediators that can do that. Okay? Now, thinking about arachidonic acid going down the other pathway, well, that's this cyclooxygenase pathway, or COX, and that's where drugs like aspirin and NSAIDs, but also steroids, can decrease the enzyme production of cyclooxygenase. ACE, those are enzymes. Well, what are they producing? Well, if arachidonic acid goes down this pathway, it's going to produce prostaglandins, including other prostaglandins and things like prostacyclin, but also thromboxane A2. Right? So what are they doing? Well, they're also causing vasodilation, and they're also causing the recruitment of other things to stimulate that. Well, vasodilation means that there's more of the white blood cells that are going to show up. Things are going to come there, more fluid leak out, more edema. Okay? So what are steroids doing? They're blunting this process that reduce inflammatory cytokines. They inhibit the recruitment and activation of new eosinophils or neutrophils, depending on which disease you're thinking about. That reduces the infiltration. All of that together reduces the vascular permeability so that it changes the vascular permeability so it doesn't leak. No, so it reduces the edema, the swelling. That improves airflow, reduces the exact things that cause exacerbations. It also, when you use these inhaled steroids, they improve the bronchodilator response when you need them. So it does that by increasing the number and the density of beta-2 receptors. So now they are more likely to respond to the bronchodilator when you need it. Now the problem with steroids is that we're affecting genes. That's a biologic effect. So the drug might have been there and now it's gone, but the effect can take a little bit longer to unfold. So inhaled corticosteroids don't work like that. The onset is about 1 to 2 weeks of regular use, but it's going to take up to 4 to 8 weeks for the maximum effect of that inhaled steroid, because it's affecting the gene transcription and translation of these enzymes that is regulating this response. Now, going back to COPD, I said it's predominantly neutrophils. Well, there are some patients with COPD who also have almost like an asthma component. There's something called asthma COPD overlap syndrome. So people with certain types of COPD, typically more moderate, severe, they do respond to inhaled steroids. Not all COPD patients do. They typically also have higher eosinophil counts, typically over 100. And those patients probably do need to be on inhaled steroid along with long-acting antimuscarinic antagonists, bronchodilators, and long-acting beta agonists. So we use the eosinophils to guide us in COPD since it's not the main problem. In asthma, it certainly is more of the main problem. And so inhaled corticosteroids are first line, first drugs, you got to put them on. Before you even give them a bronchodilator, they need to be on inhaled steroid. That's how important they are. Okay? But I wanted to make sure that you understood why these drugs need to get not only to the location, but what are they doing in both of these disease states, and I hope you found it to be helpful. All right, so now that we understand the anatomy and the basics of getting that drug to the right location, mechanism, let's talk a little bit about some of the other factors related to pharmacology, like pharmacokinetics and dynamics, that might impact the way we use the drugs. Now, absorption. Okay, well, we're inhaling these. Part of the reason why we inhale that is to avoid the systemic exposure. We don't want steroids messing with other tissues and organ systems if we can help it. We want that local topical effect. But guess what? You saw in the anatomy, when you take an inhalation in, there's two pipes. There's the esophagus and there's that trachea. So you can find that about 12% of what you use is going to be going down in the stomach for it to be absorbed. So you're going to absorb some systemically from the lungs, not as much as you would taking it all by mouth. And you're going to also absorb some by swallowing the portion that stayed in the oropharyngeal tract and went down the esophagus. Okay. The next thing that I wanted to talk about, and we'll see here in a second on a table that I put together for you, is the binding potency. And we know that potency is really about how much drug do I have to give to exert a pharmacologic effect that's desired. And so the chart that I put together for you is a dose equivalency amongst the agents. You don't have to get worried about potency. Doesn't always mean better. It just means how much do I have to give. So a good example of that is fluticasone comes in two different formulations. The furoate has a stronger binding potency and half-life and duration of action than propionate does. So when you consider the two, the fluticasone furoate can be administered once a day. That's where that stuff matters. Now let's look at the table, because the table again helps us understand the doses based on the age groups that we would use them in. Okay, so you can see from the inhaled corticosteroid table here, this is put together for children and adolescents. So on the far left side, you see the list of the various inhaled corticosteroids, including our nebulized option. And then you see in the first section here is our children 6 to 12. Okay? And then over on the right side are adolescents over the age of 12 and go into adults. Okay? And then you see the low, medium, and high. And that's just the dosing amount that we're going to administer, even by inhalation. Come in different dosage formulations, different strengths to achieve that. But you sit there and you look across that and you see the amount of micrograms per day that they're inhaling per dose. Okay? And when you look at that, you just see a bunch of numbers. Now, I don't memorize this stuff. I mean, this is not, I got a lot of stuff in the hard drive and I don't have much space left. You know, things like this is what a tool like this is for, to help me and remember to look at, oh, okay, I need a medium dose inhaled corticosteroid because of their level of control, especially for asthma, you know, or a low dose, or when I need to taper down. We always need to use the least amount of drug possible. And that's what guides us here, okay? So, you know, you can see those differences in their potency that reflect in the amount that we have to administer to be given. So, again, not something to memorize, but it's a good tool to help guide us in using those low, medium, and high doses for the appropriate age groups. All right, so now let's talk a little bit about some of the side effects and common adverse reactions that can sometimes happen with this class of medication. Again, nothing's perfect, we know that, but you're inhaling something, right? So that means it can deposit in the oropharyngeal area. So dysphonia, which is basically a change in your voice, can happen, especially with chronic use. So patients can have some hoarseness, weakness in their voice, and this can occur up to 20% of patients. Why does that happen? Well, chronic exposure of steroids to tissue, anywhere it's applied, can cause atrophy. And so that's one of the thoughts, is that it may be causing some atrophy of the vocal cords. Second is irritation to the throat. Okay? You'll see here in just a second, I put together another table that summarized some of the key bigger adverse reactions that you need to monitor or keep in the back of your mind, you'll read about. And one of those is oropharyngeal candidiasis, okay, that can eventually develop. So let's jump into that table. So again, this is our side effects warning table. It kind of aligns with some of the things that we're also going to monitor for, counsel patients about. So again, understanding the why then trickles down to the obvious things. You don't have to memorize or try to think through it, or it just makes sense. So on the left side, you see the side effect, and then on the right side is a little bit of the rationale for why it happens, and then some of the response that we as clinicians should take or counsel the patient about. So we have oral or esophageal candidiasis. Okay, so that's yeast fungus. That's Candida albicans. Okay, that typically grows there. How do we prevent that? Well, that's one of the reasons why we have them after they administer the medication and it's deposited there. Let's get it out. And so that's why we provide them additional counseling and education about rinsing their mouth out and spitting it out, not swallowing it, but spitting it back out. So basically kind of like mouthwash, you gargle and you spit it out. Okay, and this is really relevant with the higher, kind of medium to high dose inhaled corticosteroids. What about adrenal suppression? So if we absorb it systemically, that means it's moving around our body. Well, these are hormones. So there's circuits, and there's the hypothalamus and the pituitary adrenal glands that kind of communicate to each other. Well, if you absorb enough of it, especially at those high doses, for long term, there can be some degree of suppression of the HPA axis. That's the hypothalamus pituitary adrenal axis. And why it matters is that if that happens, you get atrophy. The adrenal gland will just kind of slow down a little bit. So when you develop a stress response to something going on, an injury, a trauma, surgery, an infection, something, you typically have to release things to respond to it. Well, the adrenal gland may not respond very appropriately. And so you can experience, again, not commonly seen, adrenal crisis. Again, these typically are more concerning in the long-term high-dose options, especially in patients who had been on oral treatments. Okay? Because when you give it orally, the oral bioavailability is very high, very, very similar to a parenterally administered steroid. So if they are on high dose for a long period of time, and when we say long period, we're talking about weeks, 3-4 weeks, you know, that's at minimum, that minimum cut point, especially if they were on oral systemic steroids, then you may want to consider a taper through those, again, high, going down to medium and low, just to minimize that risk. Immunosuppression, we know that steroids can do that. Make it harder for us to fight things, especially again with long term. So it can set us up for secondary risk of infections. Well, we already talked a little bit about that right here. We don't need that happening, not just topically, because you're suppressing the immune system locally, and you allow opportunistic organisms to have a little party. Okay? So we do want to be careful with that. You also want to be careful with it with patients who have any ocular herpes or active tuberculosis or untreated systemic infections. Why ocular? Where's that got? Well, because remember, budesonide or comes in a nebulized treatment, so you can aerosolize it and it will get in your eyes, literally. And depending on how you administer the meter dose inhaler in particular, you can still get some in the air that absorb in the anterior chamber of your eye. So ocular, down here, is one of the problems that you can develop cataracts over time. You can change a little bit of the pressure in the eye. Okay? And so routine eye exams are at least given consideration. Monitoring for changes in vision are relevant. Bone mineral density can decrease. This becomes a real problem in our COPD patients where they work so hard to breathe that many times they are nutritionally deficient. So they're not consuming the amount of calcium and magnesium, collagen, and other things that are needed to generate good, healthy bone. And they spend a lot of energy and calories just trying to breathe. So when you add chronic steroid that's getting systemically in the system, well, we know that chronic steroid use can also facilitate decreases in bone mineral density. So you add that with the decreased nutritional issues, well, you're now creating a perfect milieu that favors and unfortunately increases that risk. We don't see it as much in the asthma patients because at least their diet is better, but the COPD patient, when you look at a lot of them, they have that barrel chest, but they're real skinny, skin and bones, because they work so hard to keep those airways open. All right, so that makes sense then on the monitoring. We're monitoring for compliance, their symptoms, exacerbations. Remember, inhaled corticosteroids are being used for prevention in most cases. All right, we may need to periodically check and monitor their pulmonary function test to see if the drugs are adequately keeping them from having remodeling, damage, inflammation, things like that. Okay. Now there's obviously the risk of side effects. We need to monitor for oral candidiasis. Are they washing their mouth out? Changes in vision. Bone pain in particular, especially if they're having osteopenia and osteoporosis. So that maybe require us to do DEXA scans, see where they're at, see if they're progressing. Pediatric patients, so a special patient population, you're going to need to monitor growth curves. One of the problems with using steroids, if you saw the cutoff was 6 years, we generally don't like to use them in younger kids where their bone growth is more rapid. There can be a small impact on bone growth. Okay. Now, let's talk about some of the counseling points. This drug class is not going to help you in an acute exacerbation. Make darn sure they know that. This is not a rescue medicine. This takes time to kick in. You're changing, again, the biology, the cells, the transcriptions of the genes are being influenced. That doesn't happen overnight. That doesn't happen in minutes or even an hour. So the maximum time that it's going to take a couple weeks for the full effect of this drug to take over and see it, right? So yes, we might initiate it in early, mild, acute symptoms, but it's really because we just need to get the ball rolling towards this prevention, stabilization, especially in our asthmatic patient. Okay? So what about this bone growth thing and the curves? Well, remember in the first 6 to 12 months, it's important that patients know, yes, there have been evidence and studies that the growth can be blunted by about 1 centimeter. I mean, a centimeter is pretty small, right? Almost hard to tell. But here's the important thing. It returns back to normal. It's not accumulative and it's not irreversible. Yes, we want to encourage diet, exercise, activity, all the normal things that a kid would go through. And we're going to monitor their growth curves. But we need to balance this because uncontrolled asthma, especially in a kid this age, also can affect bone growth and maturity. So either direction is a risk. So we want to maximize their level of control to keep them active physically, in school, engaged, nutritionally fit. So that's all important. And then the next thing is that we need to talk to our patients about, which is huge, especially with our bronchodilators. But even with the administration of our inhaled corticosteroids, is our compliance. Why are they taking this? They don't feel anything. Nothing happens. Right, because of the way it works. It's preventive. And it only works by taking it. But it's also taking it correctly. So let's take a look at that. So I put together, again, another table for you. These, again, are meant to be aids for you to wrap your mind around when you're studying and when you're talking to patients and you're really trying to help them to understand things. This is a guide. It's not an absolute. All right? So when we talk about the different techniques, you have to think about the device. So we have meter dose inhalers that come in really two different kind of formulations. They're solution-based and they're suspension-based. Suspension-based, which is historically what many meter dose inhalers were and are, means you have to shake it up and distribute the drug. It can settle at times, whereas solution-based, some of the newer technologies, distribute the drug. Okay? So meter dose inhalers also come in with different propellants. And there's been changes over the past several decades where we're using propellants that don't damage the atmosphere and things like that. Okay, they've been banned. So we got a lot of new options as a result of that. Then we have our dry powder inhalers, and they're formulated in such a way that the inhalation technique is different than that of a meter dose inhaler. Also, how you handle it, what you do with it. And then there's the nebulizer, which is different than all of them. So we need to understand the different ways that our patients are using their dosage form, especially when they have more than one, which many patients do. They'll have a meter dose inhaler, they'll have a nebulizer, they may have a dry powder inhaler with a albuterol, or I'm sorry, with a meter dose inhaler, and they're using the same technique on all of them. And that's not right. And it's not their fault, it's our fault. Because they should know different if we do our job. I'm gonna make a comment about that one more time here, because I can't tell you how many patients don't know anything about this, which means that the physician and the pharmacist, possibly the nurse, have not talked to the patient. Or maybe they did get counseling from one of us. We did our job, but they didn't listen. Well, we gotta do something to convince it needs to be reinforced. Because this drug only works if it gets to the site of action and is being taken correctly. So all the inhalers and devices have a few things with inhaled corticosteroid context here. And the first one is that you rinse out your mouth when you're done, whatever the device is. Rinse it out, swish, spit. Okay? You're not gonna wash and put the inhaler in water. Okay, you can just gently clean the mouthpiece, and you discard this thing when it's the displays typically say 0, even if it's not empty. Just stop, get your refill. So you're always using something with active drug in it. Each device looks a little different and operates a little bit different. Now let's talk a little bit about the meter dose inhaler. Again, in most cases, shaking it is required. It's pressurized. It has a propellant at some level in there to pressurize to deliver the medication out. Now, if you know it's a solution base and that formulation doesn't require shaking, fine. Is it going to hurt to shake it? No. No, we don't. The reason it matters is because we don't want to shake dry powder inhalers. There's no benefit in doing that. So there is a subtle difference there, right? If you're using a nebulizer, it says shake solution before. Well, it's really a suspension, and that's the budesonide formulation. Okay? So you do have to shake it up a little bit to disperse the medication so that it's distributing equally and not in chunks or concentrated areas. So meter dose inhalers in general, shake it up, you prime it. When you first get it, you got to maybe prime it a couple times, 4 times, before it actually actuates a drug out. And then you want to consider it after not using it for a couple days. Now just make sure that the drug delivery coming out of it is the same dose all the time. Now you may say, well, I'm going to burn through all my doses. Well, there's typically extra doses in there for that. And yes, you may have to call a pharmacy to get a refill if it ends up being excessive for some reason. But if you're taking your drug like you're supposed to, that shouldn't be needed. Spacers can be used with meter dose inhalers depending on the device. So always, again, specifically consider that. But you exhale fully. You put the device up to your mouth, Make sure your lips are not blocking the opening. And then you take a slow, deep, continuous inhalation, and while you start that, you're going to actuate the device. So you start the inhalation first, not squirt it, let it deposit into your throat with no air movement, but you want air movement to be happening while it's coming out. And you continue the deep inhalation as deep as you can, and then you can hold it. If you can wait 5 to 10 seconds, great. You just need it to deposit on that tissue. And then you can blow it out. Now, why did I say slow, deep, continuous inhalation? Because it's different. Because you have to activate the device differently. Typically, you have to puncture something to release the powder. But your inspiratory flow rates have to be greater. Now, it doesn't need to be excessive and all dramatic. It just needs to be a stronger, more forceful inhalation to get the powder out of the device and down into your lungs. And either way, you're holding your breath to allow it to deposit, then you blow it out, and then you can wait 30 seconds in between if you're supposed to give a second dose or inhalation. Again, that's specific to the dose you're using and the formulation that you have. And then when you're done, rinse it out. Okay. Now, nebulizers, people think that they're better. They're not necessarily better. If you use a proper technique of these things, they're fine. Right? But nebulizers, because it spews it out. You need to still take in slow, deep inhalations to get that drug down into the parts of the lung where it matters most. Okay? So hopefully that stress on those points is relevant, because we have the responsibility to talk to our patients and make sure they're informed, again, specific to their device. So align it to their device. But these are some general principles that impact the overall efficacy of the drug. All right. Wow. So knowing the why can better equip us to provide that personalized, evidence-based care. We got 2 patient populations here: asthma, COPD, pediatric patients. What does the evidence say about growth curves? Administration techniques. Why helps us to personalize that in a way that maximizes outcomes. Guys, we have a lot of topic reviews, and we answer a lot of questions, important things related to clinical practice at thisiswhy.health. That's there for you. My desire is to give back, to help. We all need to learn from each other. I've done a lot of things. I don't know everything, but I've experienced a lot and I've seen a lot. And there's a lot of practical knowledge there that, for those of you that find it helpful, we put it together in collections, playlists, allow you to bookmark, download tables, charts, images for your study and your use. We want you to use them. Share them with people. Sign up for the newsletter so that you can keep up to date. All right, in summary, corticosteroids remain a massive part of the treatment of chronic asthma and certainly play a role in COPD. It's about reducing exacerbations, improving the quality of life, keeping people active. When you use these drugs appropriately and administer them correctly, and your patients are knowledgeable about how and why they're using it, we can achieve that. Please like this video and subscribe to us if you're on YouTube. And if you haven't visited us, check us out at thisiswhy.health. We'll see you next time. Take care. Bye-bye.